All right, well, we'll go ahead and get started. My name is Noelle Young. I'm a neonatologist at Duke University. And on behalf of the Tiny Baby Collaborative, it's my pleasure to introduce you to today's webinar, speakers and panelists. The topic for our webinar today will be discharge and post-discharge care for infants born at or before 24 weeks gestation. So we have a fantastic group of speakers and panelists who will lead the webinar today. First, we'll hear from Dr. Bill Malcom. He's a pediatrician who leads the transitional medical home and follow-up program at Duke University. After his talk, he'll turn it over to Dr. Sara DeMauro, a neonatologist, clinical trialist, and director of the follow-up program at the University of Pennsylvania and Children's Hospital of Philadelphia. Following their talks, we'll have time for questions and discussion, and that'll be led by our moderators. On our moderator panel, Mia Malcom and Kourtney Vier are both mothers of children who were born extremely preterm. Paige Church is a neonatologist and developmental behavioral pediatrician at Beth Israel Deaconess Medical Center and Boston Children's Hospital. And Maya Dahan is a neonatologist at Sunnybrook Health Sciences Center and the University of Toronto. All right, so before we get started, just a couple of quick housekeeping points. First, this webinar is being recorded, and the recording will be posted to our website, tinybabycollaborative.org. We welcome multidisciplinary attendance at these webinars, including children and families. If you have questions that come up during the webinar, please use the Q&A button in Zoom to post the questions, and we'll do our best to get to those in the discussion at the end. As you can see, we have a multidisciplinary group in attendance today from all over the world. Thank you all for joining. On our registration form, we asked a couple of questions about the discharge and post-discharge care at your hospitals. And so I'll take a minute to go through some of the responses. First, a majority of you responded that your hospitals provide specialized follow-up for these infants. And in most cases, the neonatologists are actively involved in the follow-up process. 69% of you responded that infants can be discharged home with nasogastric tube feedings when appropriate. We next asked about components of the discharge process at your hospitals. You can see that the majority of responses indicated that the primary care provider or PCP is identified before discharge. But if you look down the list a little bit, only 46% of you responded that there's a verbal handoff that occurs to the PCP before discharge. Most of you responded that CPR training and car seat tests are required before discharge. We know that hospital readmissions are really common in this group, but you can see that just over half of you indicated that there's a discussion about the potential need for hospital readmission before discharge. And a third of you responded that there's a process to identify the closest or most appropriate ER prior to discharge. Around a third of you said that families are connected with a peer support group prior to discharge, and 6% of you said that there's a ICU tour or introduction to the pediatric ICU that happens before discharge. All right, finally, we asked about how the neonatologists and providers in the NICU receive feedback on the post-NICU course for these infants. And you can see that responses really varied here, from use of statistical reports in 32%, as well as both formal and informal updates from colleagues and families. So just a quick look ahead to Tiny Baby webinars coming up in 2026. Our next webinar will be held in February, and we'll focus on research to advance tiny baby care. So please look out for an invitation and more information to come on that. All right, so with that, I will stop sharing, and I'll turn it over to Bill to get us started.
Great, thank you. That's all very interesting pre-work. I'm excited to be able to have this time with y'all today and start the discussion about sending our tiniest babies home. So, is my slide good there?
Yes.
Well, again, I'm going to be talking about the post-discharge care and that transitioning to the home environment for our tiniest NICU graduates. I'm going to start with let me see if I can get rid of this first. Just a familiar case for a baby who might be less than 25 weeks gestation going home from the NICU. A baby who has a list of diagnoses at discharge, including BPD and pulmonary hypertension, and they may not be an oral feeder, so they're dependent on G-tube feeds. They may have had a history of an intraventricular hemorrhage or retinopathy of prematurity. And all this comes with a complex discharge for sure. They may go home with pieces of equipment that the parents need to learn how to use, and that includes home oxygen, whether it's by cannula or other means, and all the supplies that go with that. There's a concentrator and tanks and tubing and all of that. A baby might be going home with gastrostomy tube feeds or NG feeds, and again, supplies that go home with that, feeding pump, uh, uh, all sorts of things that they need to learn. And then a list of medications and a complex schedule that they need to learn as well. So we all get excited for this, right? It's graduation day. It's something the parents have been talking about and thinking about for a long time. Some of these babies can spend months, as you know, in the NICU. And so that day comes and there's all this excitement for both the family and for the staff that's been taking care of and really bonding with them. But in reality, it might be a little overwhelming. There's a whole bunch of stuff that they need to keep in mind every day in taking care of these kids. They these babies have been taken care of by doctors and nurses for all this time, and then all of a sudden, it's under their care 24/7 to make those decisions. So when we talk about a complex baby, premature infant going home from the NICU, there's really several things that we need to keep in mind. We need to address the medical care needs, the nutritional needs, the technology that may be supporting them in the home, as well as their developmental care, because those have long-term impacts for these kids. So how do we do that? How do we prepare these families to take these complex and fragile infants home? Uh, Lots of places use discharge checklists like this. We use one that's really interactive and something that the parents can get involved in and early on, so that they see all the different pieces that need to be put together to that puzzle before they go home. We give them an opportunity to meet with all the different specialists, and the nurses have a whole list of things for them to learn. And it's good for them to see and participate in that care early on, so it all doesn't happen that day or two before going home. We developed this app. This is something that the parents can load on their phone or tablet, and it allows them to have access to our learning library, which has links to different handouts and videos and things like that, infant CPR and how to care for G tubes and kids going home on oxygen and things like that. And then they have that app available to them when they go home, so that they're able to access that and remind themselves about how to do some of those things when they're not in the stressful environment. Similarly, this app we use to track them once they go home. So if they go home with special needs, we have an area for them to input things like oxygen saturations or respiratory rates, so that we can monitor them after they've gone home and really have close connections with the family. And it really provides them with kind of that peace of mind knowing that someone's looking after them and they're not all alone at home with their fragile baby. Similarly, we have a checklist for the providers. So no matter what the level of learning is, the provider carrying, whether it's a resident or an intern or a nurse practitioner, they have a complex list. And so we use things like this, these smart phrases and things that they can use through the medical record, so that they have an idea of what all needs to go on before these complex discharges take place. So we've developed this transitional medical home model, which is our transitions program that starts on the inside in the NICU. And these most complex babies, the ones at highest risk, are the ones who usually transfer over to our team prior to discharge. So we can get to know them, their family, the babies, and really be part of that discharge plan. And it gives them the parents a familiar face and a familiar voice when they go home, knowing that they're going to be seeing somebody who knows their baby well. We enroll these babies in our program while they're in the NICU. Like I said, we get to know them, but also if they've been admitted to the floor or if they've been going home from the PICU or the heart center, we do consults and get to know them before they go home from there as well. The babies are enrolled in our program for 1 year post-discharge. And again, these are the most highest risk of babies leaving our hospital. The extremely preterm babies, the ones with multiple morbidities and medications, if they're going home with medical equipment. And really what this does is it gives the family, as well as the primary care providers, the ER docs, access to our team post-discharge so that they can contact us and we can kind of go over the situation together and come up with a plan, knowing what we know from them. Our team is four physicians. We have three pediatricians and one neonatologist, all who have had specialized training and taking care of babies with complex care needs. We have a psychologist who does our developmental testing as well as provides social and mental health for the parents and families. We have two nurse practitioners, two nurse clinicians, those who are taking care of all the complex care and care coordination that happens after discharge. We have a unique fellowship, an infant complex care fellowship, as well as our neonatal fellows who participate in our program. And then we have our therapist, social worker who's dedicated to our program, which is extremely important to address all the resource needs that these families might have, as well as a dietitian and staff assistant. So the goals of our transitions program is really to improve that care delivery and coordination for the NICU graduates that have complex medical and developmental needs. We provide ourselves or provide them with a transitional medical home so that we are the persons that are kind of running the show post-discharge. Because we care for a lot of the uh, uh, needs that the babies have going home, such as their oxygen and their diuretics and their tube feedings. We prevent the need to have to refer to different subspecialties, and it's all in one place sort of care. It decreases the duplication of care. And like other transitions programs similar to ours, we showed a decrease in emergency room visits as well as rehospitalizations, especially in that first year post-discharge, which is such an important time for these kids. We're able to show as well that we had a decreased length of stay in the NICU by earlier discharging kids with things like NGs and things like that. Overall, this contributes to lower costs, although there is some sort of a cost in providing this program. Overall, we have lower costs for the hospital and the health system. And hopefully we have better medical and developmental outcomes that are a little harder to manage and assess. Some of the additional benefits of our transitions program is that it provides an easy button, like I'd mentioned, for the parents, the PCP, the ED. They can call us and we can triage and help them decide where the baby needs to go, referrals that need to be made, etc. And overall, we've seen a better parent satisfaction after implementing this program. There is a possibility to have different models of a transitions to home program. We do it because of our population in our NICU and knowing that many of these issues resolve after the first year of life. So in looking at the post-discharge medical issues, primarily for these tiniest babies, we looked at some of the post-discharge medical issues, including prescribed medications for those born less than 25 weeks gestation. And we looked over about a 5-year period. And of those, there were 54 babies that were born less than 25 weeks gestation who went home. And as you can see, over that first year of life, the reduction in need for medications is dramatic. Diuretic use over 60% at discharge, only 2% after 12-month period. Anti-reflux medications, again, that's very center dependent, but high amount of these babies going home on reflux meds and much reduced by the time these kids are a year old. And as you can see, almost all the medications, except for the inhaled medications for their BPD, pretty much resolve by the time they're a year of age. We also looked at the home equipment use, and similarly to the medication use, as you can see, those going home on oxygen, we had about 33% born less than 25 weeks gestation going home on oxygen, and only about a third of them still needed oxygen after 12 months. Those going home on apnea monitors, none of them needing it after a year, as you can imagine. G-tube feedings, about 35% requiring G-tubes at discharge. Only about two-thirds of them still needed at a year of age. And in G-tube feedings, they're either converted to a G-tube or they no longer needed them. And you'll see later the majority of them that no longer needed them. While the medical issues seem to dramatically decrease over the first year of life, the EI service, the early intervention services, actually increase. And so this is what we want to see from a program like this. And again, looking at our babies that are discharged less than 25 weeks over a 5-year span, about a month after discharge, about 10% were going home with physical therapy services and over 70% by the time they were a year after discharge. Similarly, you can see occupational therapy and speech therapy increased as well, pretty dramatically. And surprisingly, actually, feeding therapy, not many went home with feeding therapy. However, these seem to increase over the first year of life. So because we got so many questions about feeding and growth problems, and it's by far the number one reasons for parents and physicians to call our pager, is because of the feeding growth problems that happen post-discharge in these kids. As you know, extrauterine growth restriction is common in the NICU, and really growth is often very poor throughout their NICU stay, and it's the norm to be discharged below the 10th percentile from a NICU. Appropriate catch-up growth is really the goal for these babies, and you don't want to do it immediately. You want to do it over a period of time, 6, 9 months or more. You want to promote lean body mass. And so we don't use weight alone as a measurement, but really watch that weight to length ratio because the length is something that's often going to lag behind weight gain. In the NICU, you're going to use growth curves like the Olson or Fenton or the intergrowth growth curves. Once they are discharged, we frequently use the WHO growth curves, and we want to adjust for their prematurity. So this is a perfect sort of catch-up growth scenario for a baby born less than a kilo. As you can see, over about 6 to 9 months, it takes them to get up to the curve, and then they level out at about the 50th percentile. And when you adjust them, you apply that filter to adjust them for their prematurity, you can see they maintain their growth adjusted age right at about the 50th percentile along their entire first year of life. Some of the strategies that we use to optimize their catch-up growth after discharge, we use aggressive fortification of breast milk, either fortifying the breast milk with things like human milk fortifier or infant formula powders, or we supplement the breast milk with straight formula, transitional formulas, trying to mix them up to at least 22, 24, 27, even 30 calories per ounce. We try to use formulas that are high in protein and high in calcium and phosphorus. if we are going to fortify the breast milk. We want to maximize their feeding efficiency, so the use of feeding therapists to really make sure that they're using the right utensils for feeding, STs, OTs, and lactation specialists. And then we want to minimize the impact of their comorbidities on their feeding by managing their lung disease and their reflux and the sort aggressively as well. As you know, in the NICU, human milk has been shown to be of so many benefits for our extremely preterm population. Unfortunately, especially when we're looking at catch-up growth, human milk alone is a little short on the macro ingredients that we need for catch-up growth. So calories and protein alone are usually a little bit less than desired for extremely preterm infants. And there's a large variation depending on the mother's milk. Similarly, human milk alone has inadequate micronutrients as well, particularly the minerals and the vitamins are a little bit short for our extremely preterm population. And this leads to evidence of metabolic bone disease if we're using breast milk alone in many situations. I only mentioned gastroesophageal reflux because you're going to have to deal with it after kids leave the NICU because oftentimes it doesn't peak until about 4 to 6 months corrected age, which is typically after one of our extremely preterm babies has already left the NICU. And there's lots of different mechanisms why this is such a big issue for our extremely preterm population. And the way I address it is really taking a stepwise approach. And you're really trying to buy time more than anything because it is going to resolve over the first year of life. And supportive care is going to be your number one means for improving reflux and the symptoms related to it. Supplemental tube feedings, the last thing I want to talk about, and I want to talk about G-tube feedings and NG feedings. As you know, oral feeding is a barrier to NICU discharge in many situations. And traditionally, the last 1 to 2 weeks of a NICU stay was really for the purpose of learning to take all feeds orally. We've kind of transitioned a little bit more towards supporting home NGs and G tubes as needed in the home environment by trying to get kids out of the NICU and at home. There was a couple studies that I mentioned here that estimated between 20 and 30% of the entire NICU population is often working just on oral feedings for discharge. Unfortunately, there isn't a lot of randomized controlled trials to help guide us to best practice, whether it's waiting until they take all POs, discharging home with an NG or G-tube, and what the long-term outcomes might be. Certainly, as all other sorts of areas of neonatology, there's center differences that occur across NICUs, and this is ever so important and noticeable in feeding practices. No consensus guidelines of who should go home with G-tubes or NGs, but it's a significant number of babies who are going home with G-tubes, and there's wide variation in those who even offer home NGs. Certainly, there's been several studies that have showed it's going to decrease your NICU length of stay. It also actually reduces healthcare utilization. And when you compare home NGs versus G-tubes, G-tube population has certainly more ED visits and readmissions due to complications of the G-tube compared to NGs. Several studies have looked at growth outcomes and have shown that there's really no difference long term in going home with an NG versus full POs. Regardless of going home with an NG or G-tube, for catch-up growth, you need to make sure that you're adjusting the volume of the feeds. And for about that first 6 months, what we do is just increase weekly by 5 mLs if they're a bolus feeder. And then if they're getting continuous feeds, we increase by 2 milliliters an hour. If you've already kind of reached where you want to reach in the middle of the growth curve and you're just doing maintenance growth, then we do this every other week as opposed to weekly. Parent satisfaction is high in those that go home with NG feeds, and well over 90% say that they made the right decision when parents decide to go home with an NG, and most say that they were prepared for it as well. When we looked at the first 400 patients enrolled in our transitional medical home program, 57 of those were discharged home with an NG tube, excluding 12 patients who either weren't candidates for G tubes or withdrew from our program. 45 patients were actually included in our analysis, and only 5 of them ended up needing a G tube. The lower gestational age and those babies that were taking less than 50% by 44 weeks PMA were the ones who were most likely to have a G tube. So really the keys to a successful home NG program is determining in your facility what is the success rate going to be and determining what your eligibility is going to be. Again, we looked at those taking at least 50% by 44 weeks and having a positive trajectory. And then those also who had physiologic stability, because the kids that had more severe BPD and the extremely low gestational age were the ones that had the most difficult time weaning from the NG. There has to be a good discharge planning and education and good close follow-up with support of both the parents and the primary care physician after discharge. We published these guidelines in the Journal of Perinatology a couple of years ago. I know you can't read this, but there are some guidelines that can kind of guide you through this as well. So thank you very much. I'll stop sharing. And I'll pass it over to Sara.
Thank you. That was so interesting. I enjoyed that. All right. Let me see if I can share my slides now. Is that okay?
That's great.
Great. Thanks, Noah. All right. Thank you so much for the opportunity to be here and to share some of the lessons we've learned in our program here at CHOP about transition to home, neonatal follow-up in general, and some thoughts about transitioning to home specifically in infants with lung disease, since of course we all know that BPD or bronchopulmonary dysplasia is so very common, particularly in our tiniest babies. So jumping right in, we'll talk a little bit about the neonatal follow-up program, hopefully to provide some guidance to folks who maybe don't have a program yet or are thinking about how they might go about starting to launch or grow a program to focus on the needs of tiny babies. And then again, some things we've learned about discharge considerations in kiddos with BPD. So we'll talk about, my sort of guiding principles about the role of a neonatal follow-up program for high-risk babies, some specific considerations when building or expanding your program, how to address capacity problems, and a little bit about our care model. So what is the role of a neonatal follow-up program? Why is this important, particularly in the context of discharge of high-risk, very small babies? So I would say we have sort of 4 pillars of things that we do in the neonatal follow-up program. So in children with risk for medical or developmental problems due either to prematurity, or in this case, very extreme prematurity, or to illnesses or exposures that happened around the time of or after discharge, we aim to identify emerging neurodevelopmental differences and medical sequelae of these early exposures as early as possible, so that we then can establish clear plans of care for these developmental and medical problems in partnership with families. We provide tremendous amounts of psychosocial support for families, and we conduct research that is aimed to improve the care and the outcomes of high-risk children and their families as well. So if one were to build this from the ground up, I think there are a few key aspects. So first off, neonatal follow-up programs do not pay for themselves. I'm amazed by everything Bill shared with us. I'm sure he could tell us, could spend an hour telling us about how he pays for his program. Most of these programs don't pay for themselves. So it really is a matter of institutional support, buy into the mission that if we take care of small babies on the inpatient side, we really owe it to them and to their families to continue taking care of them after discharge. You need a lot of space to do this kind of work. Again, this is an institutional commitment. It takes a lot of buy-in on a lot of levels. You need to build out a multidisciplinary team. It was great hearing about Bill's transition team. This includes people with expertise in developmental care of high-risk babies, medical care of high-risk babies, sort of deep partnerships with people who can provide psychosocial care to our families, and then partnerships, because we do not work in silos and we really do need strong bridges with partners in the community. Early intervention, medical providers in many, many different subspecialties, oftentimes pediatricians, so that we really can send our families out into the world feeling empowered to connect with the people who are going to provide ongoing and really intensive care for their babies and their children over the first days and weeks and even years. And then a plan. So who do we see? What do we do? How do we do it? And when do we do it? So there are recommendations from the American Academy of Pediatrics about who should be seen in a developmental follow-up program. These are relatively old recommendations at this point, but they do recommend that infants should receive follow-up assessments based on the severity of the perinatal problems, interventions received in the NICU, risk factors of the families, and outcome profile of the individual NICU, and of course, resources, as I had mentioned. At our program, that equates to anybody born at or before 32 weeks of gestation, or infants with a laundry list of risk factors that are shaped around these guidelines. We could spend lots of time talking about how one might shape a program around these recommendations, but certainly in the context of tiny baby care, I think we would be hard pressed to find someone who would argue that a tiny baby does not fit into this rubric and doesn't deserve intensive follow-up after discharge. And then once we get them in the door, what do we do? These are some of the many domains of assessment that need to be considered in the development of a sort of a model of care for your neonatal follow-up program. So certainly we do the standard cognitive, motor, and language development, oftentimes with the Bailey, but not always. But especially as children get a little bit older, we pay particular focus on behavior and attention, executive function, school readiness. I think quality of life is an important consideration, and I'll share some quality of life data at the very end of this talk. We think a lot about functional and adaptive skills. So not only what are the child's, say, cognitive development or motor development skill acquisition, but how does that child function in a home environment or school environment? How do we ensure that they really can get by and be a productive and happy member of the community? We spent a lot of time thinking about how to support parental well-being. And then all of the physical growth aspects the physical health aspects that are so critical, making sure that children are growing well, as Bill was telling us about, making sure that we have a good handle on their vision and hearing. And then all of the medical sequelae that we know are more prominent in our population of small babies or babies who were sick around the time of birth. So keeping an eye on their respiratory health, renal health, and cardiovascular health as they grow. And importantly, making sure that families understand that even while the children are starting to get better, not taking so many medications and really looking quite a bit better from a medical standpoint over the first months and years, that they do remain at risk for long-term health problems in these medical domains, and that these always need to be considered, and they're within the context of their prematurity. And as I was just alluding to, difference in some of these domains do emerge over time. So, while the first year of life is exceptionally critical from a medical standpoint, getting off respiratory support and getting off medications and getting off tube feedings, it's after that first year of life that some of the differences in some of these other domains start to emerge, which is why long-term follow-up within the context of a developmental home or a developmental care provider type program is so essential. And then, of course, the classic line, if you build it, they will come. You spend all this time building an exceptionally strong neonatal follow-up program. And we have big problems with attrition or loss to follow-up in the world of neonatal follow-up. And this is something that people who provide long-term developmental care to high-risk families are sort of constantly bemoaning. How do we get people back in the door once we have our program? We did some work with one of my fellows a few years ago, talking to families who didn't come back. Why didn't you come back, and what were the barriers to coming back for follow-up in our program? And, learning from families about where the barriers were. And so I think some of these representative quotes, are really informative. There are so many other appointments. It is so hard to coordinate, especially between the other medical appointments, other developmental appointments, and then, of course, full-time work for families. Families go back to work and have to squeeze this in among all the other responsibilities in their lives. Or the struggles when of watching your child go through developmental testing. They tried to rush him with tasks. He got frustrated, threw the day off. It was hard. Experiencing that with your child is, can be quite a challenge, and something that we could anticipate and help counsel families around. Or my pediatrician said it wasn't necessary, right? So an opportunity for us as developmental care providers to, again, build those bridges to the community and make sure that other folks understand the importance of what we do. We categorized all of the barriers that families described for us into these 4 domains: logistics, time, perceptions, and emotional stress, which gives us the building blocks for then thinking about how to tackle some of these barriers, and really ensure that we have a program that not only is a first-rate program, but really ensures that families are getting in the door and having the opportunity to experience the care that we can provide. So some of the specific things that we've done within our program, we actually discuss follow-up beginning in the NICU. It's actually a standard part of our team meetings that we have with families as they're getting closer to discharge. We employ peer navigators and social workers that support families to get in. We do our best to have flexible hours and scheduling. More often within the context of research, but sometimes within the context of clinical care, we can pay for parking or help families travel, or even sometimes travel to them. This is actually a van that we actually really did purchase for one of our studies to help get families in. Other things, childcare for siblings. This was an important barrier that we identified during COVID. If siblings are not allowed, or if we don't have a way for them to be monitored during the time that a patient needs a visit, it really is a tremendous obstacle for families. We have mountains of healthy snacks and diapers available. We are working hard to use remote or virtual assessments whenever possible, especially for families for whom it's particularly complicated to get a child into the hospital, such as a child with, dependence on multiple technologies. We work hard to make our assessments relevant, right? So, is it helpful to sit down with a family and say, well, your child's Bailey cognitive score is two points lower than I would have expected it to be, right? Is that helpful? Does that help a family move forward and make good decisions and provide the best possible support for their child, and understand the growth trajectory of their child? So we really work hard to make sure that the data that we're providing back to families really is going to help them better understand how to care for their child. And then timely research results are essential for people who are participating in research studies with us. It is an essential aspect of giving back and sort of closing the circle. Now I'll just transition a little bit to talking about special considerations both before and around the time of, and sort of anticipating discharge, specifically in infants with BPD. I spend a considerable part of my time doing research in this domain, and it's sort of been my long time love. So I'm excited to share some of the things that we've learned in here. We know that BPD occurs in at least half of surviving extremely preterm infants. We know for sure that there are long-term associations with mortality, development, lung function, and healthcare utilization. And we've been doing a lot of work both around the developmental and the respiratory care of these infants as they're transitioning to home that I will share. So what is the incidence of BPD in our tiny babies? So again, focusing on the most important children for the group of people who are on this call today. It of course depends on definitions, as all things do, but if you use the definition of oxygen use at 36 weeks, that you can see that among surviving 22 weekers, about 78%, will have BPD at 36 weeks. At 23 weeks, 84%, pretty steady in this 22 to 24 week range. We also can look at, and I will share the details of the grades on the following slide, but a more nuanced grade-based definition. So based on the level of respiratory support that's provided to the child at 36 weeks post-menstrual age, you can see that among infants born at 22 and 23 weeks, far more than half will have grade 2 or grade 3 BPD, which means they're on more than 2 liters, and about 1 in 5 still on invasive mechanical ventilation at 36 weeks post-menstrual age. Just to sort of write it all out, this is that data-driven definition of BPD I just showed you. So these are the grades. Grade 2 is high flow nasal cannula or positive airway pressure at 36 weeks. And again, 1 in 5 of our tiny babies still on invasive ventilation at 36 weeks. So how do we think about these kids, especially the ones who are on high levels of respiratory support as they're nearing 36 weeks, term-corrected age and beyond? So in our program here at CHOP, we have a large multidisciplinary program specifically for the care of infants with severe BPD. And it's a referral-based program. Children come from all over the region and sometimes beyond for the multidisciplinary care that we're able to provide. And so those infants end up staying not only till term-corrected age, but much beyond. So the data on this slide are from the infants in that program over the first decade or so of our program. And these are data about motor skill acquisition at 3 and 6 months corrected age in infants with severe BPD. So infants who remain hospitalized because of their BPD far, far beyond their due dates. And we evaluated their early motor skill acquisition. So were they acquiring the skills that would be expected of a child at 3 months corrected age or 6 months corrected age? And then we compared whether they were gaining these skills, losing skills, or not acquiring them at all. And we looked at 10 different typical developmental milestones. So what you can see in this figure, along the x-axis are all of the sort of 10 milestones that we were evaluating. And the infants depicted in blue are those who had normal development in each of the milestones at both 3 and 6 months corrected age. The ones in the red bars had atypical but improving over time skills in each of these areas. And the ones in the green bars were persistently abnormal or even worsening between 3 and 6 months corrected age. So what you can appreciate is about a third of our infants with severe BPD have abnormal or worsening skills in simple things like visual tracking and fixing. Close to a half don't reach in the midline or put their hands in the midline or are unable to do those skills or are losing ability to do those skills over those first few critical months. So this really told us, this was a call to action for us. These infants are actually in the hospital still at this time point, and they are not developing the skills that we think they should be developing or worsening right in front of our eyes. And, these are things that we could really be working on while these infants are with us in the NICU. So building on that, we developed a program of early progressive mobility. This is something that's been done for a while in the PICU and adult critical care units, but has really never been done in intubated babies in a NICU before. And this program supports the mobilization of intubated infants as soon as medically tolerated. So our intubated babies start by getting skin to skin and out of bed around 32, 34 weeks corrected age on a regular basis for therapy. Then they get their therapy on and off the crib surface. You'll walk around our unit and see intubated babies on a mat on the floor getting therapy. We put them in seating devices, swings and chairs, especially as they learn to have better head control. So we have intubated babies in swings, which I think, or high chairs, which is pretty unusual, I would argue. And we frequently will be putting them prone so that they continue to work on their strength and their mobility. Does this work? Well, as we implemented this program, we did some standardized motor assessments in our intubated infants, both before and after the implementation of this early progressive mobility program. We assessed the infants with a test called the TIMP, the Test of Infant Motor Progression. And we did the TIMP at about 44 weeks and then about 50 weeks, about 6 weeks apart, in all of our intubated babies, both before we implemented this program and then again after we implemented this program. And you would hope that over time, infants are acquiring motor skills slowly but surely, as I showed you in our prior slide. Most of them gain some skills slowly. And you can see before we implemented early progressive mobility, the change in the TIMP score over that 6-week period on average was about 1.5. After we implemented early progressive mobility, you can see that the average change in TIMP score over 6 weeks was 4 points. So more than twice as high. These infants are acquiring motor skills significantly faster after implementation of this program. So these data are small. This is 40 babies, but I think this really tells us that there is an opportunity in our sick intubated babies around this time of term corrected age and beyond to make sure that we're really pushing hard to implement therapies aggressively that are going to help them acquire the motor skills that they need to grow and learn and thrive. Unfortunately, it is not universal that babies are getting that level of therapy. The data on this slide are data that we recently gathered from 22 NICUs in the BPD Collaborative, which are NICUs across the United States and some in other countries that all have multidisciplinary care programs for infants with BPD. And we surveyed those NICUs and we did a point prevalence survey. So on 2 days in the fall of last year, each unit collected data about their intubated infants with grade 3 BPD. Their infants with grade 3 BPD. They didn't have to still be intubated at this time point. So the average PMA of the 141 infants for whom we collected data was 49 weeks. So again, just, this sort of peri-discharge, getting close to discharge, just past term corrected age. And as you can see, there is a close association between the level of respiratory support that these infants were receiving and whether or not they were getting therapy. And you can see that most infants had not received PT, OT, or speech therapy in the prior 48 hours. And if you look at infants who were still intubated or on high levels of non-invasive support, it was about a third to a half who had received PT in the prior 48 hours. Less than that received OT or speech therapy. So, most infants are not getting aggressive therapy regularly in our NICUs in order to support their development. And there is a close relationship with the level of respiratory support, such that the ones on higher support are really not getting what I would argue they really need to be getting. So this really frames for us an opportunity to start thinking about ways to develop better care for our intubated infants and our infants with grade 3 BPD, as long as they're in the unit. And so we are working on those things now, both within my own unit and within the BPD Collaborative, so that we can really continue to think about how to improve care, developmental care in the unit, which then bridges to all the things that we would do outpatient. As we transition these babies home from a developmental care perspective, every single one needs to be referred to early intervention. We should be screening them both in the NICU and after discharge from the NICU, using the CP guidelines to make sure that we identify high risk for CP or cerebral palsy as early as possible. And we should be referring all of these babies to our developmental follow-up programs to make sure that they continue to get the care that they need even after discharge. And then let's just talk a little bit about respiratory care. So that's all developmental care of infants with established BPD, but there's a lot that needs to be learned also about how to support these infants from a respiratory standpoint. And I would argue that if they're not receiving the support they need from a respiratory standpoint, it makes it very, very hard to participate in therapy and to gain the skills that are so essential that I was just talking about. So how do we think about management of respiratory care in infants with BPD? I'm going to take a step back here for the next few slides and tell you about a study that we did in infants with BPD who were no longer intubated. So these are not necessarily those grade 3 BPD infants I was just talking about, but more children that fall into that grade 2 category, infants who are extubated on non-invasive support, cannula or CPAP. And there are some pressing questions about how much hypoxemia do they have? How quickly can we wean them? How quickly can we get them off respiratory support? Should we push them off respiratory support in order to get them home versus going home with supplemental oxygen, which of course is, a tremendous commitment for a family. And does it matter? So we did a study here at my hospital, a pilot study that we called the BPD STAR, or BPD Saturation Targeting Trial. And we completed this study a couple years ago and just published it earlier this year. And we wanted to know whether in infants with established BPD, does targeting a higher oxygen saturation range as compared to a lower range decrease the incidence of intermittent hypoxemia and total time of hypoxemia over that time between, when they're diagnosed with BPD, around 36 weeks, and up to about 6 months corrected age. So in order to answer that question, we performed a randomized clinical trial. We included infants who were less than 30 weeks at birth, and we randomized them at 34 to 44 weeks postmenstrual age. So they were, already extubated at that time point, and we're still in our NICU. Our primary outcomes were intermittent hypoxemia and proportion of time with hypoxemia. And as you can see in the little table I popped on here, our infants were on average about 25 weeks at birth, 735 grams at birth, mostly males. They enrolled at about 40 weeks postmenstrual age, and they remained on our study monitor for about 22 weeks. This was our study monitor. This is a hospital grade Masimo oximeter that we put on every study participant. And then we attached that little dongle that you see on top, which transmitted the oximetry data to our study team real time so that we could monitor patients at all times in the unit and out. We reviewed histograms of their oxygen saturation values every week and titrated their respiratory support in order to try and keep them in their target ranges for about 6 months. Here's what we learned. So this is the average number, the average number of intermittent hypoxemia events per 8 hours over the time between 36 weeks and 66 weeks postmenstrual age, with the infants randomized to the high SAT group in pink and those randomized to the low SAT group in blue. And as you can appreciate, especially in the first, say, up to 48 weeks postmenstrual age, in those first couple months, it does seem that there are more events in the low SAT group as compared to the high SAT group. Looking at this from a numbers standpoint, over the entire time period, based on our primary definition of intermittent hypoxemia, there was not a big difference in the number of events per 8 hours. And we did it per 8 hours because that would be sort of the average number of events per night when a baby's sleeping. Although in that first 4 weeks, between 40 and 48 weeks postmenstrual age, there is in fact a higher incidence of hypoxemic events in those randomized to the low SAT group as compared to the high SAT group, both for the shorter events, 30 seconds long, and for events that were 60 seconds or longer. We also looked at the proportion of time infants spent with a saturation less than 80. Again, over the entire time period, you could see the lines do sort of converge around 48 weeks postmenstrual age, with maybe a hint of some separation in the earlier weeks. And again, over the entire study period, no difference in the proportion of time with hypoxemia, though a suggestion that maybe, a little bit more hypoxemia in those first 8 weeks among those randomized to the lower oxygen saturation group. So despite the fact that some infants were randomized to a higher group and some were randomized to a lower group, there was not a significant difference in the numbers of infants in this study who were ultimately weaned off or discharged home on respiratory support. I think it's important to recognize that even in this relatively low risk group of kids, in the sense that they were not intubated at the time they were randomized, still almost half went home on respiratory support. A third were rehospitalized before 6 months corrected age, and a third had to go to the emergency room or urgent care in the first 6 months. We asked the families about how they perceived quality of life in their infants, and importantly, in the first few months, parents seemed to think that their infants randomized to the high SAT target group were less likely to say that their child was unhealthy. Those who knew that their kid was having lower oxygen saturation seemed to perceive their infant as less healthy. But that difference did get less over time. And by 6 months, there was not a difference between the groups and parental perception of the child's health. One of the important things we learned in conducting this study is how challenging it really is for a family to be home with a pulse oximeter. We were talking with these families weekly, often more, sometimes more often than weekly. And, the alarm burden, we experience alarm fatigue in the unit, but for a family to be experiencing alarm fatigue in the home environment is really an enormous problem. And it's not something they can walk away from the way we can when we're taking care of babies in the unit. And so something we learned is that clinicians don't spend a lot of time thinking about alarm limits when they send a baby home with an oximeter. In our study, we had the luxury of deciding whatever we wanted for the alarm settings, and we actually chose pretty liberal alarm settings so that the alarms would not go off very often. But what we wanted to know is what's the impact of the alarm limits that people usually choose for these types of babies when they're going home on a monitor. So we took some data from participants in our trial, and we did a simulation study to say, well, what if you choose different limits? How many alarms would a family be experiencing at home with these babies? And this figure from our paper, I think, is pretty eye-opening. There's 3 different things you can choose. You can choose an averaging time, 8 seconds versus 16. You can choose a delay, 0, 5, 10, or 15 seconds. So how long does the saturation have to be low before the alarm goes off? And you can choose a threshold. How low does the saturation need to be before the alarm goes off? And so there was not a big difference based on the averaging time. But what I'd like to point out is that most people in our institution at the time we did this study were discharging babies with no delay and a saturation threshold of 90%. And as you could see based on that first red arrow, that leads to about 20 to 25 alarms per 8 hours in an infant such as the ones in our study. You can imagine that a family would throw that alarm out the window, because how could you possibly listen to an alarm going off 25 times every 8 hours? If you just change the threshold to 80%, what I would argue is more clinically informative, and a delay to 15 seconds, again, more clinically informative anyway, you might get 1 alarm every 8 hours. So it's really, it really hopefully will make you think, if I'm going to send a baby home with this technology and with this device in order to support them, how do I also support the family in making sure that this is something that they're actually going to be able to use, and not want to pull their hair out and not make them angry at us because we're setting people up for failure. And finally, I want to just take a step back and think about long-term impact of BPD in our very, very small babies. Again, these are data from our program here at CHOP. We talked a lot today about, going home with a tube feed and going home with medications and going home with oxygen and going home with an oximeter alarm. And what does that mean is in the transition to home? But as we transition babies and families to home, we also want to help frame for people, what does this mean? How is this going to feel potentially for you in the long term as a family? And how do we set everybody up for success? And so these data and this figure here are from our chronically disease program at CHOP. And we called all of the families who had participated in our program over more than a decade, and their children were anywhere between 1 and 12 years old at the time we called them. And we talked about current level of technology dependence and medication use, and how does all of this impact on quality of life for the child and family. And what we learned is that the good news, as you can see in the top figure, over time, the solid black line in the top figure, no respiratory support, the numbers of children on respiratory support decreases very, very quickly over the first few years of life. So that, by school age, most children are off respiratory support. Most children are no longer wheezing, and most children are walking around independently, right? So medical things get better and better and better. But that doesn't mean that there is no longer any impact of that child's chronic illness on the child and family. And what you can see in the bottom panel are the results of the PEDS-QL, which is a pediatric quality of life inventory. And as you can appreciate over the school age years, other aspects of the chronic illness do creep in, and troubles with academics and troubles with behavior and troubles with attention do creep up and do have important impacts on the child and family, such that you can see the emotional health-related emotional health, school health, and parent-reported health of the child really do decline over those first few years. This is something we can anticipate. It's something we can help families prepare for. And if we do that together in partnership, we can make sure that we set everybody up for success and prepare them for the future. So with that, I will stop. I just want to say that in conclusion, our neonatal follow-up programs bridge the transition to home, help families identify and address developmental and medical challenges. We think specifically about our kiddos with BPD. Remember that hypoxemia is common, and targeting a higher oxygen saturation in those, first few months after a diagnosis of BPD may decrease hypoxemia and may be important for long-term health. When we discharge families with BPD, we really need to be thoughtful about care coordination, anticipating some of the challenges that they may encounter from developmental and medical perspectives over those first few months, and help prepare them for that. And we do this all with the help and support of incredibly complex and valuable multidisciplinary teams. So I have many funding sources to thank for the fun work I get to do, and I will stop sharing so that Bill and I can hear some questions from the group.
Great. Thanks so much, Sara and Bill, for those excellent presentations. So we'll go ahead and transition now to questions and discussion. Before we get going, I'd like to just start by taking a moment to give Kourtney and Mia a chance to just briefly introduce themselves, and then we can go ahead and dive into questions for the last 15 minutes here.
Like Noelle said, my name is Kourtney Vier. I am the parent of a 4-year-old boy. He was born at 23 weeks and 0 days. He was born at the University of Iowa Hospitals and Clinics in Iowa City and spent around 6 months there. While his time there, he was diagnosed with BPD, pulmonary hypertension, and feeding difficulty, which meant he would only take bottles from me. He was on an oxygen for a total of 2 years and had an NG tube a year, actually, or 6 months after discharge, and had it for 6 months total. He was rehospitalized 2 times, one time at 8 months and again at 1 year, both related to respiratory illnesses. At 2 years old, he was diagnosed with cerebral palsy, and at 4 with epilepsy. Post-discharge at 9 months, he began speech therapy, occupational therapy, and physical therapy. All of those therapies 2 times a week, so 6 appointments a week. So he's a very busy guy. He is now in preschool and still is receiving all of those therapies outside of school, but is receiving them at school as well. He has 2 siblings. We have a very happy and healthy family, and he is thriving at 4 years old. So I'm proud to be represented here, and proud to share a little bit more about Zeke and our family's experience.
So I am Mia. I am the mom of a 16-year-old who was born at 24 weeks and 5 days in St. Louis, where we live. And he spent 268 days in the NICU at St. Louis Children's Hospital. He went home with a couple of accessories. He had a trach when he went home. He went home with a G tube on oxygen. He had his trach for about 3 years. He had his G tube for, I think, around like 4 or 5 months. And he has been getting OT, PT, and speech for the majority of his life. He dropped off PT, I think, when he was about 12, and he still gets OT and speech to this day. He has 2 appointments every week now, his OT and PT. So we are incredibly blessed and privileged to be able to support our son with all these interventions. He also gets them at school and has since he started school. He was diagnosed with many things, but amongst them, he did have BPD, Yeah, and his feeding challenges were a little bit different, but he still had feeding challenges. And he does have cerebral palsy diagnosis as well as developmental delays. He had a grade 4 IVH, but he is 16 and he is thriving and a sophomore in high school, and that's a separate set of challenges. So glad to be with you all today to participate in this talk. Should I do the first question now? Just throw it. Okay, so I am going to take the first question. Before I do that, I wanted to say thank you to Bill. During his talk. He talked about, like, one of the first things you mentioned was about like discharge day and how it's so fun and great. And then you're like, and also the reality is that parents are like stressed out and scared and nervous about this day. And I just wanted to say thank you because I really appreciate that. I don't think it's talked about enough that there is duality in that moment for parents. And then um, Sara, I just wanted to appreciate your family-centered approach to information sharing, understanding what people need and how to approach them where they are. So I just wanted to say that first. But there was a question that popped into the Q&A. I think it was for Bill, but I wanted to answer it live because I thought it was interesting. So thank you to Betsy for your question. She said, what is the socioeconomic breakdown of your patients sending home and NG tube or complex medications feels scary in our population, which often does not even follow up appropriately with their primaries?
Yeah, I mean that's that's a big question for sure, and it's a great question, and I think I think we try to do our best to make sure that we're supporting regardless of what resources are needed in the home. Certainly, when sending home kids with medical complexities, we need to make sure that the child's going to an environment that is well supported, and so we have our social workers involved in every little bit of our evaluations, doing the social determinants of health, both before and that first time that they come back to our follow-up clinic to reassess. And, the needs are a little bit different after the child's actually in the home. And I think it's great to make sure that we have all areas. I think as a medical provider, we're always so focused in on the medicine of it, and we need to give this medication, we need to give this type of formula or supplement with this sort of breast milk feed or whatever. But in all reality, the success is going to be the whole package. And so you need to make sure that whatever you can do to get the family in to be there for discharge education. And then sometimes that just means a lengthier stay to have a successful discharge. And making sure that the family is supported in the home. And we do a home assessment, especially for kids going home with a lot of technology needs. And so, but yeah, I think addressing the whole package is extremely important. I hope I answered that question to what she was asking for, but.
Yeah. I just wanted to say quickly, and I will shoot to Paige. I also think one of the things as a parent, like who lived in that unit, I think one of the things that we have to really consider with parents is like how safe of a space we create with them so that they're able to tell us what their barriers are. Because a lot of times people are embarrassed by their barriers. You know what I mean? Like you don't want to be the person who says that they don't have a crib because then people are looking at you like, how could you not have a crib? You knew you were having a baby. Well, I also didn't know I was going to be here for 9 months. So that's awkward. But I do think it's just like really important to think about what people's barriers are. And to your point, Bill, like, how do we help solve for them instead of like making it a barrier to them, like getting out of the hospital? Like, how do we help you solve? So I just wanted to say that, and I will pass it to my good friend Paige.
Thank you. Oh my gosh, that was so amazing. And I actually have my clinic team. We were wrapping up clinic. They're in the corner listening and saying how amazing this is. So thank you, thank you, thank you. I'm going to pull on Mia's theme a little bit and talk about, that anxiety and that like duality of going home. Both of your programs are incredible. I'm not sure if I didn't hear it, but how do you weave in the parent as the person who's doing a lot of this stuff, the facilitator, so that that transition can be less overwhelming? I mean, the data is incredible. And then as a corollary to that, Recently, I was at another talk with Dr. Jennifer Arnold from Children's, and she has this incredible program of simulation where parents of children going home with technology can literally have like a modified bedroom with no monitors, and they will change trachs and do all this stuff. And so, is there a chance to incorporate some of her work into the programs, the incredible stuff you're working on? And sorry, just to feed that to the parents, would that have helped?
Yeah, I certainly can take a little bit of a stab at that. I think it, there are also other questions in the Q&A about sort of curricula and teaching. And, we absolutely have curricula for everything. You don't send someone home with an NG until the parents placed it themselves a million times and they feel super comfortable with it. And we do a tremendous amount of teaching, certainly for a baby with a tracheostomy. There's literally a binder, right? And you go through it at the pace that is appropriate for every family. But, and people often will do a 24-hour stay similarly, in a room with only a remote monitor and no monitor in the room. But it does need to be very family specific. Some families will put an NG in once and say, I'm done. Like, I know how to do it. I feel confident. I'm ready. I'm happy. Like, get me out of here. And some will do it 10 times and still feel nervous and squeamish and worried and anxious. And right. And so we have to hear that. We have to see that. And we have to really titrate the level of education, the level of support to the needs of the family so that when they go home, they can fly.
Yeah, I would love to hear from me and Kourtney on those questions because that's what really matters, I think.
agree.
Yeah, in our experience, we did I did stay overnight with my son as part of like a checklist of how we had to, say goodbye. And I was fortunate enough in my own circumstance to be able to be there every day that he was in the NICU. I will say one of the concerns I have maybe with like the simulator, which would have been a very helpful piece. I would have enjoyed that. Sometimes when you get home post NICU, depending on your insurance company, who you use as a provider, your pulse oximeter might be different, your concentrator might be different. And so learning even the mechanics of how do I use a concentrator? And if I don't have this tube plugged in the right way, it will alert. It's not, is it humidifying at the right amount? I don't know. And so I think if possible to connect with that post-discharge company that does provide you with those tools, like an oximeter, like a concentrator specifically for our circumstance, and to know how to use those equipment. Because we lived 2 hours away from our home. And so the person who received our oximeter or the oximeter and the concentrator was my mother-in-law. And so she received the education from that person and then gave the education to us. And as you can see, that's a little bit of telephone and difficulty in that. And so my question would be, is there a possibility that whoever is providing those materials for home, could that be done in the hospital? And I know there's maybe some insurance complexities that exist inside of that, but just a thought.
I would just say really quickly, one of the things that, so again, Gavin went home with all the things and the stuff, right? And I think that one of the things that was very helpful for me is that I had, when you're doing the educations and when you're doing the trainings with families, there's oftentimes like you're doing it and there's 65 eyes on you, like watching you do the thing. And it's a very high pressure situation because it's not a doll, right? This is my baby. And if I mess this up, it's like, am I going to kill my baby first? But then all these people are watching me and are they going to judge me? Right? Because you all do this for a living. I just had a baby and like now I'm his pulmonologist and his ENT and I didn't know that's what I was signing up for. And so I think that like I had a really great nurse who always told me like, hey, we can kick everybody out and it's just you and me. There is no pressure, no judgment. It's going to be okay. Like whatever happens right now is what happens and we grow and we learn from here. And I think it's really important for it to be okay that I say like, I'm not okay with this. Like I'm still scared because he went home with a trach and I was not comfortable with his trach until he was 3 and he got it taken out. Like I wasn't comfortable. That's not a thing that I'm comfortable having to manage my child's airway. Like that's not the contract I signed with my kid when I got pregnant, you know? And so I think like starting at that space of like understanding that this is always going to be high pressure for families. And there may not come a point where they're like, yes, I'm ready. I'm so good to go. And they're always like, I don't know, I'm nervous. It doesn't mean they can't go home. It doesn't mean they can't take care of their baby. It means that they're a human being having a human experience around their child. And then to also to Kourtney's point, like our home health team brought the equipment that we were going to take home to the hospital. And we had that during our overnight stays with Gavin because doing it with stuff that I wasn't going to go home with wasn't going to work for me. So we had that at the hospital, which was very, very helpful to be able to like trial and error in the hospital with his stuff that we were going home with.
I also think, great point, Mia. I think learning how to troubleshoot stuff, like if you hear, it's not a quiz, oh, if you hear this alarm, what does that mean? But more so like, here's the things that we've heard from parents that are in trouble, and if you have feedback loops from parents who have been discharged, whether that's in your follow-up clinic, I hope you would get that. And I'm sure parents would be happy to answer some survey questions about their discharge experience so that you can be helpful in the future, especially if you're following up with those parents and children in the discharge. But here's some things that we've heard from parents that would help you to troubleshoot. And it is a lot of information all at once, but having something come to mind like, oh, when I gave my son albuterol at 2 in the morning, it's normal that his oxygen level would go down. And I don't need to be afraid of that. And I can wait for a certain amount of time before I need to make a phone call. And so knowing those challenges by potentially asking those parents in discharge so that you have a list of, hey, here's some troubleshooting options that we think would be helpful for you to know, and maybe making a list that would be available for them.
I mean, those are some excellent points, and thank you for two excellent talks. And to continue off of some of the comments that have already been made, and I think that Bill and Sarah, you've alluded to in your talks. It sounds like we have slightly different discharge expectations for babies who are born at 22, 23 weeks compared to our babies who are born at, say, 30 weeks, right? And from what Mia's talking about and Kourtney's talking about is how are we helping prep those families who have babies at 22 weeks well before discharge. So not just in the few weeks before discharge, but really from the get-go to really be able to empower them moving forward and to have those expectations well before they get there. And to tag on a few questions all at the same time is how do we also incorporate that primary care nurses? And I don't know if every unit has primary care nursing, but in my experience, and I think a few of our experiences, primary care nursing can really help sometimes verbalize the things that parents may not feel comfortable asking to the team. So maybe I'll throw that large loaded question to both of you.
I'll start off by saying I think there's a real importance to primary care nursing, and we actually have in our transitional care nursery kind of a core group of nurses who take care mostly of that convalescence discharge planning time period. And I think that's extremely important because they really know how to prepare families for discharge, and they're used to that and they're comfortable with that. You know, their wheelhouse is not taking care of a brand new 22-weeker who was just born and the intensity of that. You know, their skill set is really in preparing for discharge, and so we try to kind of do a little tour down to that area early on. And this is what kind of is going to be the next step. And you'll be transitioned over to our transitions to home team. And we kind of try to start preparing when the level of intensity dies down a little bit. I think parents, or at least my experience, is how much they hear, when they're just worried about their child breathing. It's not the time to talk about, how complex the discharge is going to be probably at that time. But I have found that kind of when that level of intensity dies down a little bit and everyone can take a breath, then I think you really got to start early because if you start talking about discharging and all this equipment and medications and feeds and do all that 2 days before going home, it's not going to go well. It's not fair for anybody, really.
I completely agree. It's a process and it it builds, right? And I, I don't know. I think there's probably not one perfect way of doing it. I would love to hear what Kourtney and Mia have to say if they have a sense of like what's the right timing to start to talk about what discharge is going to look like.
I mean, I would just say from my perspective, I think talking about discharge is one thing. And I also think just always like casually thinking about or mentioning like, if once you guys go home, like these kind of things, or like, at home, this might look a little bit different. And what we would do is X, Y, and Z. Like talking about how it'll look different at home instead of saying the words discharge, because I think once you bring up the word discharge, people are like, I'm going home Thursday. So like I would always make sure, like, even when I was in like a parent mentor space, like talking to families about like pro tips about when their baby gets a trach and like, hey, this is what it'll look like when you go home. And I know it feels really scary right now, but they can still be a regular baby. And yeah, you'll have this kind of equipment possibly, but like thinking about how to set up a room, right, for your child when they go home with all of this extra equipment. Just talking about it as if it's a normal part of life, because it will be a normal part of their life. And you don't necessarily have to call it discharge education, but you're having a conversation about what that's going to look like without being explicit. And then when it's time to have the official discharge talk, then you talk about discharge.
I also think just, phrasing it as the journey to home. The goal is not to keep that baby in the hospital for as long as possible. The goal is to get that baby home. And so I think it even starts with, in the consult before I, gave birth to Zeke, I was told generally for babies born at this gestation, here's our the success rate, I don't, that wasn't the word used, but 65% of 22 to 23 weekers at the University of Iowa hospital end up surviving and going home. And I remember hearing that. And then I also remember hearing, and they generally stay anywhere between 1 to 2 months after their due date. And so in my head, I had this idea of like, okay, maybe 1 to 2 months. And that changed. My son went home a couple months or 3 months after his due date. And I felt was really, thankful that along the way that was discussed, like, here's the stages and here's the journey. And so here's the things that we're looking for to get you to home and to get him home. And I think talking about it, maybe not so strictly, using the word discharge, or just talking about, hey, we're all on a journey together. Here's what this is going to look like. Here's where Zeke is. And honestly, I remember some of the most casual conversations that I had with doctors who would pop in and say, how's Zeke doing? I want to hear about this. Here's what this is going to look like. And some of that, like, it didn't feel scheduled to me, but it probably was scheduled for them, and their intentionality to get to know me and my husband and to talk about here's what life looks like. It wasn't necessarily a checklist that I was handed, but a personal connection that they had with us that I really appreciated. And so maybe for some of you that doesn't come natural, and maybe make it a checklist that you don't show parents, but I really appreciated those moments of here's what that's going to look like.
First of all, I just want to thank Kourtney and Mia because your perspective has just adds so much to this session. It's just been terrific. And I one of you, I can't remember, one or both of you had alluded to parent mentoring programs. And I'd love you just to talk because I could see how that could be helpful and not so helpful in different situations. And would love to just hear a couple words on that if you don't mind.
So I will say, once my son went home, my son was 10 when I went back to the hospital to like start volunteering, as we call them family partners, but parent mentor. And I volunteered for a year, and then I started to work at the hospital as a family partner. And I think that there is something so valuable to talking to someone who understands where you're sitting. Because I think a lot of times we have a lot of nurses and doctors and people coming into our room, and it's like, I know this is hard for you. And I think in some capacity, you know that it's hard for me, but at a certain point, it gets really frustrating because you don't know how hard this is for me because you've never had to sit in this room with your baby and make life and death choices and listen to all the medicine and listen to people on rounds tell you how sick your kid is and not say anything positive. Like that's not your experience of your child. And so when you have somebody who is able to come in the room and say, hey, I was here 5 years ago and, I'm at home with this kid now, and it might not always be rainbows and sunshine, but we did survive this thing. We did get out of this place. We were able to do this. And here are some tips on how we did it. And also just let me listen to you because your friends don't understand. Like how many of your friends have had 24 weekers or 22 weekers? You know what I mean? And your parents don't necessarily understand. So having somebody who gets it, who also is working with the medical team, we did a lot of education and support for the medical team of like how to break bad news to somebody or how to have a hard conversation and practice on me before you go in YOLO into this room and, possibly break some trust or like create a barrier to like really doing the thing that you know how to do really well. One thing I know how to do really well is be a NICU parent because I've been one for 16 years. So like we bring different expertise into the place. And I think that it's so valuable when like you have parent mentors, family partners, whatever you want to call them, working in collaboration with the medical team, because it gives the parent and that family so much more cushion and support and like it helps them feel seen and valued in that space in a way that is not necessarily common and like baked into the space. It's a medical space, medical professionals are the most important people, they're the smartest people, all those things. But the reality is that at some point you're going to be off work with my child and I'm always going to be on the clock, And so how do we figure out how to coexist in this space and collaborate in this space and like be a real team in this space? And I think that's what the family partners and mentors were able to do for that team, which I think was really amazing for families. So
I personally was not a part of any parent groups. That was a personal choice of mine. I felt a little overwhelmed with our circumstance, and so I chose not to. But I will say one thing, that's a little off topic, but on topic. I did. One thing I really appreciated was we, in our NICU follow-up program, we had a neonatologist and a fellow of our choice that we got to follow up for 2 years post discharge. And what I loved about that was I felt the safest with them. They saw Zeke through 6 months. They saw me and my husband through 6 months, and their continued collaboration, and work to know like, hey, we're not changing, Zeke's medications quickly. I have heard that not all neonatologists follow up with in the discharge process. And that gives me anxiety thinking about that because all I would think is, I don't know who you are and where you're going to change my child's medications. And I think there are ways, Dr. Malcom, you talked about ways to bridge that gap with getting involved before the child is discharged, which I really appreciate. But I think that if I had not had that same two neonatologists sitting across from me talking to me about, hey, this is it. When Zeke got sick post-discharge, he's like, hey, this wasn't when he got Pseudomonas and he was still, intubated. This is a croup and he's only on a nasal cannula. You know that you can be calm about this. And I appreciate it just because, like I said, those built relationships for 6 months that then continued until he was 2 years of age. That was life-changing for us. And I can't imagine doing it any different. So I really appreciate those neonatologists who have the time to follow up post-discharge.
All right, thank you so much. We're over time, but I think this discussion has been just really valuable. I want to thank our speakers and moderators again for sharing your experience with us. Thanks to everyone in the audience for tuning in and contributing to the discussion. We have just maybe 1 minute. I wanted to just ask Mia and Kourtney if you have just one final word that you'd like to leave before we sign off here.
Do you want to go first, Kourtney?
You got it. Yeah, I would just say, you spend for us, I we spent 6 months watching you guys drive the bus, or people like you drive the bus. And then I have now spent the last 3.5 years driving the bus, for a lack of better example, but of my child's care. And I think that all of you can make a difference in the confidence that you give to parents and the way that you empower them. And so being with them from day one to a day 182 and maybe all the way up until 2 years, like my experience, I think knowing us, hearing from us, understanding our home challenges, whether we have other kids at home, we work full time, whatever it is, listening to us and being a support to us matters so much, because that empowers us and gives us the confidence to care for our children and not to be so afraid that all of a sudden I have to do all the things that you were just doing, but by myself or with my husband or partner. And so I think your impact is greater than those small conversations and the plans that you guys take to care well for parents really matters for the overall success of those children. And so thank you so much for coming in and tuning in and listening, because obviously there's an importance that you have to care for parents and children that matter. And so thank you so much for your work.
And I would just say quickly, I always would tell people that, for a lot of people, the NICU might be the start of their medical journey or their relationship with medicine. And so, and the NICU, unfortunately, it's kind of morbid to think about, but the NICU breeds the next generation of, patients for any children's hospital, in wherever they are. And so I think it's really important for you all, kind of to Kourtney's point, to remember that you are starting the book of someone's medical journey, and that is a really heavy responsibility, but you're also up to the task. This is what you trained for. This is what you went into, medical school debt for. You got this part, and we are really, really in the most vulnerable of states, and it is a trauma-filled space, and we need the support just as much as you're pouring all of this love and support into our kiddos. Don't forget about us, because we're sitting there and we're scared, and we also need somebody to say, hey, I see you. This is okay. We will figure this out together, and give us that confidence, because to Kourtney's point, for 268 days, for 9 months, you guys drove that bus, but I'm 16 years into this bus driving, and it's not an easy journey. The bus has broken down a couple of times, but I felt prepared because I had really good teachers. So don't forget that you have that responsibility too. And we want to learn. It's our kid. Nobody cares more about that baby than that family that's in that room supporting that kid. So thank you all so much for showing up and taking the time and being willing to learn and think and adjust and all those kind of things, because it really does matter to parents and to families that you all even take the time to do things like this. So thank you so much for coming.
Right. Thank you. That was perfect. Thanks. And we hope to see you at our next webinar in a couple of months.